Okay, now let's move on to our neurologic disorders. For our neurologic disorders, on the other hand, we have here increased intracranial pressure. I will show you what it would usually look like later. So your increased intracranial pressure is the result of the amount of brain tissue, blood, and cerebrospinal fluid within the skull at any one time. So in this case, nagkakaroon ng increase of the amount of any of the following. The normal intracranial pressure is 0 to 10 millimeter mercury, with 15 millimeter mercury as the upper limit of your normal. So increased ICP is commonly associated with head injury and may be seen secondary to brain tumors, subarachnoid hemorrhage, and toxic and viral encephalopathies. So the volume and pressure of these are usually in equilibrium. This brain tissue, blood, and your cerebrospinal fluid. But because there is limited space for expansion within the skull, an increase in any of these components would already change the volume of the others by displacing or shifting CSF. So what happens is that there's the increasing of the absorption or diminishing the production of your CSF or decreasing cerebral blood volume. So I'll show you so this is actually your subarachnoid hemorrhage. Also, this is an example of internal hemorrhage. Maybe due to a contusion or due to a vehicular accident, nauntog yung ulo ng pasyente. What happens is that it could lead to hemorrhage. The hemorrhage will then compress the brain. Take note, the skull of an adult cannot expand. If you compare that with infants, again, for the infants, diba, hindi pa fully developed ang skull nila. So, pwede pang mag-expand pag nag-i-increase yung intracranial pressure. But in the case of adults, again, limited lang yung space. So, what happens? Nako-compress yung brain. Kaya nagkakaroon ng increased intracranial pressure. So, for our pathophysiology, again, any insult to the brain, either because of trauma, what else? Either because of hemorrhage or any tumor that is growing in the brain. This would then eventually cause tissue edema, which will lead to increased intracranial pressure. Take note, mag-i-increase pa yung intracranial pressure after this. So, pag nag-increase yung intracranial pressure, the ventricles of the brain, please take note, the ventricles of the brain are a communicating network of cavities filled with cerebrospinal fluid. So, the ventricles of the brain are compressed, so naiipit sila. So, what happens? Pag naiipit sila, naiipit din yung blood vessels. Kung naiipit yung blood vessels, again, cerebral blood flow or blood flow in the brain is compromised. Eventually, nagdi-decrease yung oxygen sa brain. Because of the decreased oxygen in the brain, nagkakaroon ng growth or nagkakaroon ng necrotic tissue or namamatay yung tissue sa ating brain. What else? Mas nag-i-increase pa yung intracranial pressure because of compression of the brain stem and respiratory center. What happens? It will also release or accumulate carbon dioxide. Your carbon dioxide would again trigger the vasodilation of blood vessels in the brain, which would eventually, of course, attract more fluid into the brain, kaya mas nag-i-increase pa ang intracranial pressure. Again, if this is not treated immediately or if it is not addressed immediately, it could eventually cause death in the patient. So for your clinical manifestations, number one or the earliest sign is always your altered level of consciousness. How will you assess this? You will have to look into early indicators such as slowing of speech, lethargy of the patient, and we also have delay in response to verbal suggestions. So we also have other signs and symptoms. We also have here decreased cerebral perfusion pressure. Again, in this case, it can result in a Cushing's response or Cushing's triad. Please take note that in restlessness, usually, this is without any apparent cause. Bigla na lang nagiging restless ang pasyente. What else? With further deterioration, coma and abnormal motor responses in the form of decortication, decerebration, or flaccidity may occur. For your Cushing's response, this would refer to a rise in the systolic blood pressure and the widening of the pulse pressure and reflex slowing of the heart rate. So that is for your Cushing's response. Nag-widen ang pulse pressure, nag-i-increase ang systolic BP. What else? Nagkakaroon ng slowing of the heart rate. For your widening of your pulse pressure, what do you mean by that? Pulse pressure, again, would refer to the systolic blood pressure. Sorry, pangit ng sulat. Minus your diastolic blood pressure. So your pulse pressure is your systolic blood pressure minus your diastolic blood pressure. The normal range of our pulse pressure should be between 40 to 60 millimeter mercury. Sorry, dalawang M dapat yan. That is the normal range of pulse pressure. If it goes beyond that, again, that would indicate problems with your heart. In the case of your Cushing's response, nasabi natin na nag-i-increase yung systolic BP natin. For example, normally 130/90 yung pasyente. After a few hours, naging 200 tapos 100. So if you're going to deduct that, ang pulse pressure ng pasyente natin is 200 minus 100. That is 100 millimeter mercury. So that is beyond the normal range of your pulse pressure. For your Cushing's triad naman, it would refer to bradycardia, bradypnea, and hypertension. Okay, let's go to your assessment and diagnostic. Common ones that are used are your CT scans and your MRI. Rare din kasi yung PET or your positron emission tomography. So ICP monitoring provides useful information. So in this case, usually nagkakaroon ng ventriculostomy. So they're going to look into the pressure of the brain. So nagkakaroon ng monitor to monitor the increase in the intracranial pressure of the patient. Again, in this case, we avoid lumbar tap because it would further worsen the damage, and it would lead more to your increase in your intracranial pressure. So what are the possible complications? We have brainstem herniation. In this case, let's focus on your brainstem. Normally, ganyan dapat ang itsura. But after, of course, your epidural hematoma that is causing increased intracranial pressure in the brain, nako-compress lahat ng parts of the brain. An example na nako-compress would be the brainstem. So normally, ganyan yung itsura, but now, ayan. Nag-herniate. They go beyond the skull. Diabetes insipidus and your SIAD or your syndrome of inappropriate antidiuretic hormone can also be a complication that would result from the compression of your hypothalamus. Again, what happens here, yung antidiuretic hormone natin, either nasosobrahan or kulang yung napuproduce ng brain or the hypothalamus. In this case, in your diabetes insipidus, this is a condition where we have your polyuria or frequency in the urination. So, para mas maintindihan ninyo, diabetes insipidus is also known as DI. So, DI can stand for daming ihi. So, polyuria, the patient would start urinating very frequently because kulang ng antidiuretic hormone. The antidiuretic hormone is a hormone produced to avoid or to prevent the urination, to control urination. In SIAD, on the other hand, is actually the opposite of your DI. In your SIAD, there is too much antidiuretic hormone that is being produced. So what happens? The person is retaining fluid in the body. So there is edema. What else? We also have hyponatremia kasi masyadong nalusaw yung salt or yung sodium chloride sa katawan. Okay. Not sodium chloride, sorry. Sodium levels in the body, which would eventually cause problems with the heart. Next, we also have here management for your ICP or your increased ICP. We focus on invasive monitoring of your ICP. So in this case, other than your ventriculotomy, we also have here your assessment using your assessment of the level of consciousness of the patient, your Glasgow Coma Scale, your input and output, strict input and output monitoring, Oxygen levels of the patient should also be monitored. So we also try to decrease cerebral edema and lower the volume of your CSF. How do we do that? By providing or giving medications such as osmotic diuretics. The one that is commonly used is your mannitol. So it reduces intracranial water, which would eventually be urinated by your patient. So very important or very strict tayo sa monitoring ng input and output ng ating pasyente. Fluid is restricted, and then another thing is that mannitol is actually given as a bolus medication. So that is through the IV of the patient. We also have here is your dexamethasone that is used as a corticosteroid that would help lessen the production of fluid in the brain. CSF may also be drained in some cases. Ayan, how do we usually control fever? That is by using antipyretics. We also have your hypothermia blanket, with the use of your chlorpromazine. Your chlorpromazine is a medication that is used to control shivering. If the patient, however, is not responsive to conventional treatment, barbiturates or your pancuronium is given to the patient. Patients with increased intracranial pressure must be in critical care units. Ayan. For nursing management, again, assessment would focus on level of consciousness and others. For nursing diagnosis, actual na nursing diagnosis, if ever affected yung reflex ng ating patient, would be ineffective airway clearance. But if the reflexes, the cough and the gag reflex of the patient is not affected, then of course you will not use this as a nursing diagnosis. Another would be ineffective breathing pattern, ineffective cerebral tissue perfusion, deficient fluid volume related to fluid restriction, risk for infection. So those are some common nursing diagnoses which we can use for patients with increased intracranial pressure. So what are the things, or how do we address these problems? So maintain patent airway through oxygenation, discourage coughing and straining. Why? Again, na it adds more pressure to the brain. We mentioned about coughing and straining would add more pressure to the brain. Auscultating lung fields and elevate the head of the bed. The elevation of the head of bed would be up to 30 to 45 degrees, unless of course it is contraindicated, or your semi-Fowler's position. Adequate breathing pattern naman, how do we maintain that? By monitoring respiratory irregularities. Bradypnea is another example. Optimize cerebral tissue perfusion, or we will try to maximize the perfusion of oxygen into the cerebral tissues by maintaining the patient's head in a neutral position. Take note, flexing the muscles or flexing the neck of the patient would compress the jugular vein. Compression of the jugular vein would increase the intracranial pressure. We also have here your maintained with the use of a cervical collar if necessary to promote venous drainage. Ayan. Avoid extreme rotation and flexion of the neck. We mentioned yung jugular vein ng pasyente. Pag na-distort yan or na-compress, mag-i-increase pa yung ICP. Hip flexion naman, this position causes an increase in the intra-abdominal and intrathoracic pressures, which would produce a rise in your intracranial pressure. What else? Avoid the Valsalva maneuver. Again, because this would stimulate your vagus nerve. When the vagus nerve is stimulated, there will be increase in your intracranial pressure. Provide stool softeners para hindi na kailangang mag-strain ang ating pasyente. Note any abdominal distension. Avoid enema and cathartics. Avoid suctioning longer than 15 seconds. Pace interventions mean dapat this means that you would have to make sure na hindi sabay-sabay lahat ng mga ginagawa para sa pasyente natin para hindi sila ma-overwhelm. What else? Your intracranial pressure should not rise above 25 mm mercury and should return to baseline within 5 minutes. Maintain a calm atmosphere and reduce environmental stimuli to avoid emotional stress, which would further increase the intracranial pressure of your patient. Ayan. For other interventions, meron na dyan. For your altered level of consciousness, please take note, this is not a disorder, but this is a symptom that is felt in certain disorders, usually neurologic disorders, such as, or the causes for your altered level of consciousness may be neurologic or metabolic. Ayan. So in this case, altered level of consciousness means that the patient is not oriented. He does not follow commands or needs persistent stimuli to achieve a state of alertness. So we have their different clinical manifestations, potential complications. Okay, please take note that the Glasgow Coma Scale is the best way to assess level of consciousness of our patients. So we have here different steps on how we assess the level of consciousness of our patients. Kindly read through those. Now let's go to your seizure disorders. Your seizure disorder is also known as your epilepsy. It is a symptom complex of several disorders of brain function characterized by recurring seizures. So again, they may be related to trauma, problem with or reduced cerebral perfusion, infection, electrolyte disturbances, poisoning, or tumors. For your seizure, this is termed as episodes of abnormal motor, sensory, autonomic, or psychic activity, or any combination of this. So for your assessment and diagnosis, we have here number 1 is that usually doctors would start ruling out specific problems. Ano ba yung nagkakos dyan? Ano yung mga possibility na related na disorders? So they would have to remove first kung ano yung mga possibilities. Tapos pag na-narrow down nila yan, then that's the time they will be able to diagnose it. Again, of course, your history taking is very important. Your EEGs will also be used to monitor brain activity. What will trigger the seizure of the patient? Usually, EEG din yung ginagamit. Okay, what else? Take note that when you're going to observe the patient, observe them before, during, and after a seizure episode. Very important yan. Yung aura, the actual seizure, and the post-ictal stage of the patient. MRI is also being performed for, again, this is significant if there are lesions in the brain. Your single photon emission CT naman is used to identify epileptogenic zones. So areas kung saan greatly affected, areas of the brain that is greatly affected by the seizure. Clinical manifestations, of course, we have seizures. Take note there are different types of seizures or different classifications. We will discuss them after this slide. Before a patient usually starts having a seizure, they would have what you call an aura. So this is applicable mostly in complex partial seizures, and we also have here your general seizures. An aura is a premonitory or warning sensation may occur before a seizure. So usually, they would feel a sensation or may nakikita sila, naririnig sila before they start having a seizure. So parang this is a sign that would take place before they would have the actual seizure. An example is may nakikita silang flashing light. May naririnig silang sound. What else? They will have parang may sasabihin silang may nalalasahan silang kakaiba. So those are examples of your aura. For your seizure, actual seizure naman, there are different classifications. 2 main classifications are partial or your focal seizures, and we also have your general seizures. For your partial, again, it only involves a part of the brain, while for your general seizure, it would involve the entire brain from the onset. Under your partial or your focal seizure, again, this is divided into 2, simple partial and your complex partial. For your simple partial, again, it affects part of one cerebral hemisphere and consciousness is not impaired. In this case, consciousness is not impaired. Please take note in complex partial possibility na nagkakaroon ng problem with consciousness of our patient. So again, in this case, pag simple partial, only a finger or hand may shake, the mouth may jerk uncontrollably, the patient may talk unintelligibly, may be dizzy, may experience unusual or unpleasant sights, sounds, odors, or taste, all without loss of consciousness. Sa complex partial naman, the patient remains emotionless or removes automatically but inappropriately for time and place, may experience excessive emotions of fear, anger, elation, or irritability, and does not remember episode when it is over. So in this case, usually nagkakaroon ng alteration already with the memory of the patient. For your generalized or your grand mal seizures naman, also known as your tonic-clonic seizure, Again, both hemispheres of the brain are affected. So in this case, it usually has what you call your tonic-clonic contractions. Kaya siya tonic-clonic. Why? Because tonic would mean stiffening, pagtigas. And then the next episode after the tonic stage or tonic contraction would be your jerking movement. Jerking movement. So those are the two things that happens during your generalized seizures. Stiffening or your tonic state, and the next would be the clonic stage where there is already jerking of the muscles. So there are simultaneous contractions of diaphragm and chest muscles produce characteristic epileptic cry. Tongue is chewed, patient is incontinent of urine and stool, convulsive movements last 1 or 2 minutes. The patient then relaxes and lies in a deep coma and breathing noisily. After the seizure of the patient, the next stage would be the post-ictal stage or the post-ictal state. After the seizure, patients are often confused and hard to arouse and may sleep for hours. Many complain of headaches or muscles fatigue and depression. So again, this is the post-ictal stage or state that is after the seizure already. I will show you examples of seizures. These are not the actual illustrations of seizures. Hindi siya yung actual na seizures mismo. Because this was only portrayed by some medical students. I cannot really see a specific one. But again, this would generally give you an idea of what are the different kinds.
Partial seizures occur when the excessive electrical discharge is limited to one part of the brain, a single hemisphere, or just part of a lobe. The symptoms of the seizure will vary depending upon the specific location in the brain where the focal seizure originates or spreads to. Simple partial seizures. Person remains aware, cannot completely control function or behavior, commonly referred to as auras. These seizures or auras are characterized by strange or unusual sensations, a whirling or tenderness in the stomach area, odors, or visual abnormalities. Other characteristics of SPS include sudden or restless movement, hearing distortion, and a sudden sense of fear. Alteration of consciousness or memory is generally not associated with simple partial seizures. Complex partial seizures. Person experiences impaired consciousness, cannot completely control function or behavior. Complex partial seizures are often preceded by an aura. Auras are not unconscious acts. They are the funny smells, tastes, déjà vu, fear, and many other conscious warnings patients may experience. They are often identified by the manifestation of complicated motor and sensory action. There may be some change in consciousness or memory. A partial seizure seen here in the temporal lobe may spread, becoming a generalized seizure. A generalized seizure affects the neurons of the entire brain. A generalized convulsion occurring in 2 phases. Tonic phase, stiffening of the muscles, the person loses consciousness and falls as the body grows rigid. Clonic phase, body extremities jerk and twitch. After the seizure, consciousness returns slowly. When the person wakes up, they are often confused or disoriented. Characterized by a complete loss of awareness. The person may stare into space and appear to be daydreaming or in a daze. Absence seizures are not preceded by a warning, aura, and are followed by normal activity by the individual. There is very minimal movement during the actual seizure, so many times it may go unnoticed by others. Some types of seizures, especially if prolonged or repeated frequently, can damage the brain.
So we have here the examples also. Okay, so those are examples of your seizures. Yan. So again, for your simple partial, it would only affect certain parts of the body and the patient still gains or the patient still has his consciousness, while for your complex partial and for your generalized seizure, consciousness is usually affected, especially in your generalized seizure. For your tonic-clonic contraction, again, that is for general. So there is what you call your stiffening and then the twitching and jerking movements of the patient. After that would be the post-ictal stage or state of the patient. So now what are your medical management for this one? Very important would be airway and adequate oxygenation for patients. What else? IV line. For medications, of course, to be administered through IV. Obtaining blood samples for analysis. Other medications such as IV diazepam, lorazepam, or your fosphenytoin is administered slowly in an attempt to halt the seizures. So general anesthesia with a short-acting barbiturate may be used if initial treatment is unsuccessful. So in this case, to maintain a seizure-free state, other medications such as phenytoin and phenobarbital are prescribed after the initial seizure is treated. Surgery may also be done if, again, the cause of the epilepsy or the seizure is because of tumors, abscesses. We also have cysts or other anomalies in the brain. Again, surgical removal of the epileptogenic focus is done for seizures that originate in a well-circumscribed area. Ibig sabihin, if they will remove that, it will, or yung mismong area kung saan nag-focus yung area of the brain kung saan nag-focus yung nagkakos ng seizure, kung maaalis yon as one, of course, it would lessen or it would stop the seizure, then they will do surgery. If, however, the epileptogenic focus would be scattered on parts of the brain, then of course, surgery is no longer indicated. For nursing diagnosis, the common one is, of course, risk for injury, fear, ineffective coping, deficient knowledge, and other diagnoses. You can also indicate other nursing diagnoses for this one, especially that which is related to cerebral perfusion. What else? We also have problems with oxygenation. To avoid injury in a patient, turn the patient to side-lying position to assist in draining pharyngeal secretions. Please take note, this is done only after the seizure or during the post-ictal state of the patient. So again, before there would be seizure, ensure that the patient's surrounding is safe. For example, kung nasa bed ang pasyente, you make sure that the bedside rails are raised. What else? You pad the sides of the bed with pillows para ma-avoid natin ang injury on the patient during seizure state of the patient. What else? Ayan, pag meron na during the actual seizure naman of the patient, you have to make sure that dapat hindi mauuntog, hindi mauulog yung pasyente. There is nothing you can do more dun sa state ng seizure ng pasyente natin other than ensuring his safety during his seizure episode. What you can do would now be after the seizure episode of the patient. That's the time you have to turn the patient to his side in order to allow your saliva and other pharyngeal secretions to drain outside of the mouth of your patient. What else? To avoid the patient from actually or to prevent the tongue of the patient from impeding his airway. What else? Suction may also be used if nagkaroon ng aspiration sa pasyente. Ayan, padding the side rails and keep under constant observation. Do not restrain patient's movements during seizure activity because it can cause injuries to our patient. Do not insert anything in the patient's mouth. Yung sinasabi nilang tongue guard, or I forgot the term for that. We do not use that for patients with seizures because it could actually cause more damage to your patients. And so that is for the discussion on your Glasgow Coma Scale, increased intracranial pressure, altered level of consciousness, and your seizure disorders. If you have, again, questions, just send me a message. You can also post a comment on the YouTube video and also on Google Classroom so that I can answer your questions or your queries. Thank you very much.